Hi, I am Dr. Selvaraj, your surgical educator from Malaysia. Welcome back to my series of surgical teaching videocasts. These are meant mainly for undergraduate medical students doing the surgical clerkship rotation and the surgical trainees as well. I promise you will become competent in clinical problem solving and surgical decision making if you are going to watch these videos over and over again. Today, in this episode, I am going to discuss one more operative surgery procedure. Today, I am going to discuss laparoscopic anterior resection. So, what are the indications for laparoscopic anterior resection? Indications are, of course, the same indications like the open anterior resection. That is, the main indication is carcinoma of the rectum, even though we can do it for benign procedures as well. Benign tumors in the rectum. Yeah, carcinoma of the rectum where the sphincter preservation is possible. The high anterior resection is done for tumors of rectosigmoid junction and upper rectum, which includes partial mesorectal excision. The anastomosis in high anterior resection is made in the region of junction of the mid and lower third of the rectum, whereas the low anterior resection is done for mid-rectal tumors, which includes a total mesorectal excision. The anastomosis here is made at the level of pelvic floor. For low anterior resection, defunctioning stoma is made in the form of loop ileostomy. So indications, I told you already, it is mainly carcinoma of the rectum. The high anterior section for rectosigmoid and upper rectal tumors, whereas the low anterior section for mid-rectal tumors. Contraindications for laparoscopic anterior sections are big tumors like T4 tumors and patients, those who are having narrow pelvis. Anesthesia, of course, we have to give general anesthesia with endotracheal tube incision. Position, you have to put the patient in Lloyd Davis position, that is lithotomy, modified lithotomy in padded Allen stirrups. Diagnosis should be confirmed by biopsy and staging should be done by contrast enhanced CT scan. Pre-op preparation, you have to give pre-op chemoradiation for patients with T3 and T4 lesions or tumors with large pelvic lymph nodes found on pelvic computer tomography scan or endorectal ultrasound. So pre-op chemoradio should be given for T3 and T4 lesions. Adequate mechanical bowel preparation should be done the day before surgery. Prophylactic IV broad spectrum antibiotics should also be given. VTE, that is venous thromboembolic prophylaxis with low molecular weight heparin and pneumatic stockings should be done. Bladder catheterization you have to do. The stoma nurse should mark the ileostomy site for the defunctioning ileostomy. Intraoperative rigid proctoscopy is performed to determine the distal extent of the cancer. Before going to the procedure as such, let us review the surgical anatomy. Because it is mainly the resection of the rectum or anterior resection of the rectum. So we have to know only the regarding the blood supply from the inferior mesenteric artery, which is this one, this part, the inferior mesenteric artery, which is supplying the rectum and the sigmoid colon mainly. So the tumor is here, you can see the tumor is in this area, maybe in the rectosigmoid junction here, or in the upper rectum, or it may be in the middle of the rectum also. So mainly we have to ligate the sigmoidal artery and the superior rectal or superior hemorrhoidal arteries. We have to spare the left colic artery, because this is the origin of inferior mesenteric artery. You have to ligate this inferior mesenteric artery after the left colic branch. After that, okay, we have to ligate. You are able to see it clearly in this picture. You should not ligate at the origin of inferior mesenteric artery. You have to ligate after the branching of left colic. Below that, we have to ligate it so that the whole sigmoidal artery and the superior rectal artery will be cut off. Here you are seeing you have to separate the mesentery and you have to do it, but in lap anterior resection, usually we will be doing it outside the body, that is extracorporeally, after pulling the divided rectum and sigmoid colon and part of the descending colon outside. We will be doing it outside the body. Position, I told you already, you have to keep the patient in Lloyd Davis modified lithotomy with padded Allen stirrups. Surgeon should stand on the right side here. The assistant may stand on the left side, and the scrub nurse can stand by the side of the surgeon. A monitor can be placed on either side, and anesthetist should stand on the head end. And this is the modified lithotomy position. So, and here you have to you have to fasten the patient to the table properly, because you will be putting the patient in steep Trendelenburg position, and you will alter and the uh, 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 right lateral position also you will put. For that, you have to fix the patient's chest to the table adequately. And coming to the port placement, okay, the 10 mm camera port should be placed just above the umbilicus. Here you are seeing it, just above the umbilicus. The 12 mm ports at right subcostal area, and this is the right subcostal area, this one and this one, and this is the suprapubic midline. And the 5 mm ports you have to place in both iliac fossa, this one and this one. Yeah, this is the port placement. After that, coming to the exposer, after creating the pneumoperitoneum and all, the table may be tilted to right side with Trendelenburg position. Surgeon standing on the right side. The small bowel, by putting the patient in this position, the small bowel will be swept out to the right upper quadrant. If there are any adhesions between the small bowel and sigmoid colon, they should be lysed. Then coming to the mobilization, yeah, this is, you have to assess after entering into the peritoneal cavity. You have to assess the position and resectability of the tumor in the rectum. Assess the liver and peritoneum for evidence of any metastatic deposits, and you have to look the colon, the entire colon, for any synchronous tumors elsewhere. After retracting the sigmoid colon, here you are seeing it, make an incision in peritoneum over sacral promontory and dissect the retroperitoneal area. After putting an incision, okay, you have to resect the retroperitoneal area. For that, you have to ligate both the inferior mesenteric artery and the inferior mesenteric vein. Both you have to ligate, then only you can go dissect it very well. You can go up to the, you are seeing here the genotas fascia over the kidney. So ligation of the blood vessel, here you are seeing, I told you already, you have to ligate the inferior mesenteric artery, that is what you are seeing here. And Here you are seeing ligation of inferior mesenteric vein as well. So you have to elevate the sigmoid mesocolon, sigmoid colon, and isolate the inferior mesenteric artery and left colic artery, which should be spared if appropriate. Usually we have to spare the left colic artery. Ligate the superior hemorrhoidal artery at its takeoff from the inferior mesenteric artery and all the sigmoidal arteries as well. Then you have to transect the blood vessels, transect the sigmoidal arteries and superior hemorrhoidal artery. You have to spare the left colic artery. So during this dissection, you have to avoid injury to the left ureter and left gonadal vessels. Mobilization of the left colon. Now you have to incise the white line of Tolt up to the splenic flexure. That is what you are seeing here and here in this picture. This is the white line of Tolt. You have to, you have to incise it up to the splenic flexure. Mobilize the left colon from retroperitoneal structures. And during this maneuver, avoid injury to both left ureter and left gonadal vessels. This mobilization is called Mattox maneuver or medial visceral rotation. Now coming to the mobilization of the splenic flexure, which is the next step. Now you have to place the patient in reverse Trendelenburg position. And you have to divide, put the patient here in reverse Trendelenburg position, and you have to, focus the camera to the upper part here, the splenic flexure. Now you can divide the splenocolic ligament and you have to mobilize the splenic flexure. The next step is mobilization of greater omentum from transverse colon. Separate the greater omentum from the distal transverse colon and continue the dissection laterally towards the splenic flexure. This is up to the splenic flexure. Starting from here, you have to go up to the splenic flexure. You have to divide this greater omentum closer to the transverse colon. You have to divide here because you have to remove the omentum also. You have to, because this is a cancer, so you have to divide this one as well. Now you have to test the possibility of tension-free anastomosis by bringing down the mobilized colon to determine the possibility of tension-free anastomosis. So you have to bring down here and see whether it is coming down easily, so that you can make out a anastomosis without tension. Sorry, I have told that we have to remove the greater omentum. We need not, because this is not colon cancer, this is rectal cancer. So we need not remove the greater omentum. The posterior rectal resection, now we have to carry on. Carry on the dissection in the avascular plane between the mesorectum and the presacral fascia posteriorly. Here, you have to elevate the rectum and you have to dissect this area. Carry the dissection through the Waldeus fascia to the level of coccyx. The Waldeus fascia is the fascia which is connecting the posterior part of the mesorectum to the anterior presacral fascia. So this fascia, Waldeus fascia, you have to divide, then only you can go up to the coccyx. The mesorectum is mobilized laterally towards both the right and left pelvic side wall. During this maneuver, you have to preserve the hypogastric nerves on both sides, on the sacrum, and as well as you have to preserve both the ureters. Anterolateral ligament will be exposed during this. This is the anterolateral ligament, which contains the middle rectal artery, which should be divided on both the sides. The mesorectum is divided laterally either with stapler or with a vessel sealer device, such as either a harmonic scalpel or a ligatio. This is what you are seeing in this picture. If we are doing the high anterior resection, then we have to do partial mesorectal excision. Yeah, partial only you have to remove. If you are doing low anterior section, then you have to remove the whole mesorectum, that is total mesorectal excision. The aim is you have to remove 2 centimeter clearance below the distal margin of the tumor in the rectum and 5 centimeter clearance of the mesorectum. This is what you have to aim at. Now you have to do the anterior rectal dissection. Put the patient, now you have to put the patient in Trendelenburg position and you have to extend the lateral facial incision up to the upper rectum. So this is what you are seeing here. So you have to extend this lateral incision anterior to the rectum. So the peritoneum is incised medial to the right ureter here in the right side. And then this should also extend around the rectum to join the pelvic peritoneal incision on the left, meeting anterior to the rectum. So both the sides you have to make the incision here, both will meet anteriorly here. In female patient, this dissection is through the rectovaginal septum, and in males, this is through the rectovesical space. Here, you are seeing it in a female patient, and this dissection is through the rectovaginal septum here. And in a male patient, okay, this is through the rectovesical space, and in males, this dissection should be ventral to the denonvillous fascia in order to spare the seminal vesicles. Next step is transection of the rectum. After mobilizing the rectum both posteriorly along with the mesorectum as well as anteriorly, now we have to divide the rectum at the pre-selected area. An endo-GIS stapler is used to divide the rectum at the pre-selected area. So this needs multiple firings of this stapler to completely divide the rectum. Ensure that vagina in women is not incorporated in this staple line. While you are doing this multiple firings, you shouldn't include the vagina in female patients. Now we have to exteriorize the bowel and then we have to resect it at the appropriate level. The divided rectum and descending colon and sigmoid colon are brought out through a para-umbilical incision which is protected by a wound protector. The proximal colon is transected at a point that allows tension-free reach of the colon to the pubic bone. Now the anvil is detached from the stapler and placed within the proximal colon. Now this is what you are seeing here. You have to pull the rectum outside through this. This is the wound protector you are seeing. So you have to bring, this is the rectal end along with the tumor, and you have to divide it at an appropriate place in the descending colon. You have to use a stapler and you have to divide it outside the body or extracorporeally. Now you have to put the anvil inside this colon and then you have to put a pursing suture around it. Now the next step is we have to do the stapler intracorporeal colorectal anastomosis. Prior to creation of the anastomosis, the proximal colon is tested to determine that adequate length is available. This you have to do. In selected cases, division of inferior mesenteric vein near its origin can facilitate this colon mobilization. Already the anvil is detached and placed within the proximal colon extracorporeally, and pursing suture is also applied. After, this is what you are seeing here, after careful deployment of the spike just posterior to the staple line, that is what you are seeing. This is the spike of the stapler. Posterior to the stapler line, you have to pierce it. Okay, then the stapler is coupled with the anvil and it is fired, completing the anastomosis. This is an intracorporeal colorectal anastomosis. See, you had to coupled here. So you had to do this coupling of the spike of the stapler and this anvil shaft. You had to couple it and then you had to fire it. The integrity of this anastomosis can be evaluated by gentle insufflation of the rectum by either a colonoscope or sigmoidoscope to rule out any leakage. While doing this insufflation, you have to fill the pelvis with some fluid. If there is any leak, you can see air bubbles there. So by this way, you can rule out any leak in the anastomosis. This is one thing. You can also see the integrity of the anastomosis by examining the tissue downwards after firing this one. This tissue downwards also you can examine for the fullness of this tissue downwards. You can also do alternate colorectal anastomosis, that is like the open anterior resection. We can also do the J pouch colorectal anastomosis. This also can be done. This is the J pouch. This also can be done laparoscopically. After this, if you are doing a low anterior resection, we must create a defunctioning or diverting ileostomy. You have to create a loop ileostomy. See, this loop of ileum is pulled out through the one of the ports. You have to pull it out and you have to create a loop ileostomy here. This is a temporary ileostomy. You have to put a rod behind the loop of the ileum. Then you have to open it immediately. And then you have to fix it to the anterior abdominal wall skin. You have to put this rod so that this ileostomy won't get retracted. This is what you are seeing here also. So we have to create a temporary defunctioning or diverting ileostomy. Coming to the post-op care, there is no need to continue antibiotic post-operatively unless there is intra-abdominal infection. Ambulation and incentive spirometry on post-op day is important for the prevention of post-operative atelectasis. Clear liquids are started on post-op day 1 and diet is advanced as tolerated. The Foley catheter is left in place for few days because of high incidence of urinary retention, especially in male patients. DVT prophylaxis should be continued until the time of discharge and can be considered as an outpatient in certain subsets of patients. Coming to the pearls and pits for the lap anterior resection, the mesorectal dissection should be performed with sharp dissection and it should be done meticulously. The colorectal anastomosis must be tension free and this may require division of sigmoidal artery at its origin and mobilization of the splenic flexure of the colon and in some cases division of inferior mesenteric vein as well. In T3 and T4 rectal cancer, preservation of the pelvic autonomic nervus may not be possible. But usually T4 cases, you cannot do it laparoscopically. In most patients, you have to use a 29 millimeter circular stapler. Using maximum size circular stapler may create radial tension leading to anastomotic leak. So you should use only 29 millimeter circular stapler. Don't use a bigger circular stapler. If the anastomosis fails, the bubble test, the anastomotic defect must be identified and repaired primarily. I told you how to do it. A protection loop ileostomy may be indicated for very difficult or low anastomosis which is just less than 5 centimeters from the anal wedge. And for patients who underwent pre-op chemoradiation treatment, There also it is better to do a diverting ileostomy. So thank you very much for watching this video. If you think that these videos are very useful, kindly subscribe to this channel and share these videos in your social media. Kindly click the bell button also to get notified for my latest videos. Thank you once again for watching this video. Let us meet in yet another episode. Until then, bye bye.